Good morning, everybody. My name's Lee Martin, and I'm the manager of the Introacoustics Academy. And it's a real pleasure to have a guest speaker speaking at today's webinar. So I'd like to welcome Dr. Barron to the stage. Just to give you a little introduction to Dr. Barron, he established and served as the director of the Balance Disorders Clinic at Ohio State University Medical Center for over 25 years until his retirement in June 2011. He received his master's and doctorate degrees in electrical and biomedical engineering from Ohio State University, and he's published over 80 articles and book chapters and has taught at national and international courses and seminars in different areas of balance and vestibular assessment and rehabilitation. So it's a real pleasure to welcome Dr. Barron to give us this talk.
Thank you, Lee. Good morning, good afternoon, good evening, wherever you are in the universe. It's a real pleasure to be here in this first webinar for Introacoustics. This is part one of the two-part series about gaze stabilization test. The title suggests that this is in VNG because that's for the most part when we assess the gaze stabilization. We do that in VNG, but the concepts are actually applicable to any test where we are interested in assessing and figuring out the diagnostic meaning of nystagmus and gaze stabilization. So just an overview of what we're going to talk about today. Healthy subjects, when they're asked to maintain and steady gaze, they can do that in the presence or the absence of visual and vestibular stimuli. They do not have eye movements, extraneous eye movements when they're asked to fixate. If they fail in that, for a variety of reasons that we will discuss later on, they will have gaze instability, and the most common form of manifestation of this gaze instability is nystagmus, which we'll be discussing the rest of this webinar. Gaze stabilization test and the VNG test battery are designed to evaluate the gaze stability and presence of nystagmus under different conditions. The three most common conditions are, first of all, the gaze test, where we examine gaze stability in different off-center gaze positions. I know most of you who do gaze tests, you also include the center gaze. That's fine, but by definition, that's not part of the gaze test. That's actually part of the spontaneous nystagmus test. But whichever way you're doing it, it's fine. It's just that that's the official definition of what gaze test is. It's off-center gaze positions. In the spontaneous nystagmus test, we look at the gaze stability primarily in the center gaze in the presence and absence of visual fixation. So you normally have part of the test where the patient has a target to fixate on, and a part of the test where the target is removed when the patient is placed in complete darkness. The next condition that we examine gaze stability is the static position testing, which we look at the gaze stability in different head positions. So in this two-part webinar, which the next one will be in the next few months, we examine the clinical significance of nystagmus in both with fixation and without fixation. In part one, we are going to talk about the nystagmus during fixation. Just to review the pathways that are involved in the gaze stabilization. Okay, so on the left-hand side of the screen, you see the peripheral structures. And these are the three semicircular canals, utricle and saccule. The information from the peripheral structures are carried to the central vestibular pathways that are located in the vestibular nuclei through two branches of the vestibular nerve, superior and inferior. At least until now, our goal in the VNG testing was just separate the peripheral and central abnormalities. So when we talk about peripheral abnormalities, we're talking about the canal and the two branches of the vestibular nerve, and then everything after that, at the root entry zone of the vestibular nerve, anything after that we consider central pathways. The areas that are in red are the areas that are activated during gaze test with fixation. So these will be the oculomotor nuclei, eye muscles, and the target is presented to the eyes, and then that information is processed in the higher central nervous system and in the cerebellum, and eventually it is transmitted to the oculomotor nuclei and the eye muscles and generate appropriate eye movements. This is true pretty much in any part of the gaze stabilization test that is performed with fixation. There's one area that might be of some interest, and is this connection of the cerebellum to the vestibular nuclei. You might ask what connection there is between the gaze stabilization with fixation and the vestibular pathways. This is what causes suppression of vestibular nystagmus. This connection primarily blocks the information that are coming from the peripheral system at the vestibular nuclei, and this is what happens when if you have for example, during the caloric testing, ask the patient to fixate, this pathway between the cerebellum and the vestibular nuclei gets activated and suppresses the vestibular nystagmus. So as you can see, the areas that the boxes that are in red, primarily in the central portion of the vestibular pathways. So in general, if you have an abnormality in the gaze stabilization test with fixation, it usually means it's a central abnormality, which we're going to discuss today. On the other hand, if you allow fixation, now many of the pathways, including the peripheral pathways here, are involved in the gaze stabilization test without fixation. What that means is that primarily when we're testing the gaze, which is the spontaneous nystagmus and similar types of nystagmus in the gaze stabilization test, if you are testing without fixation, both peripheral and central pathways are involved in this test, and generally the outcome is a non-localizing finding. Oftentimes with things like spontaneous nystagmus, you have other findings that will clarify the localization of spontaneous nystagmus, but if you're interpreting them on their own, these are non-localizing findings. You should be aware that anytime you test the patient without fixation, you will need to have some alerting tasks, and the reason for that is that generally the nystagmus can become suppressed if the eyes drift to one side and get stuck there. So unless you have cortical level involvement, you may not see the nystagmus, and the nystagmus can get suppressed without alerting. So in tests without fixation, some level of alerting is usually necessary. Okay, so just to reiterate what I just said, that in tests without fixation, by themselves, most of the findings are non-localizing, but this is the topic for our next webinar. So let's go through each one of these tests and review the procedures, and then we'll go to the findings. In the gaze test, you primarily want to record the eye movements when the patient is looking at a target about 25 to 30 degrees to the right or left, and about 20 to 25 degrees up or down. Sometimes in some laboratories they perform this test both with fixation and without fixation. I usually do this with fixation only for two reasons. It's hard to maintain off-center gaze position if you're in complete darkness, so very often the patient's eyes drift back to the center. And we do examine the eyes without fixation in the position test and other parts of the the VNG, so I don't find it necessary to do this here. But it's, of course, it's up to you. You can do it. It's not it doesn't cause any type of artifact, or doesn't cause misinterpretation, but generally it's enough just to do with fixation. So in each gaze position, you really need to record as long as necessary. There's no really time limit unless you until you're satisfied whether you're seeing nystagmus or not. Generally, though, at least you need to measure for 20 seconds or so, and then you need to inspect the tracings to see if there's any type of nystagmus. It's always a good idea in these cases to record the video as well. If it's not remarkable, you can delete it later. But if it's something remarkable, you want to keep the videos as well. So anytime you find an abnormality, it's a good idea to come back to that to make sure that you have a consistent and repeatable test result. And remember, if you've done a visual exam prior to your VNG, which I highly recommend to do, your results should match your visual inspection. If you see something that there's a discrepancy between the two, it's not explainable by physiology or pathology, so you need to resolve that discrepancy. So in the second part of this webinar, we'll talk about spontaneous nystagmus and position tests, so I will leave that for the next part. When you have a normal result, as you can see in this case, you have the patient gaze to the right, gaze to the left. There are occasional, you might see here a few bumps on the tracings. These are really not significant. It's mostly just eye blinks and things like that. If it's nystagmus, you'll see it hopefully clearly and repeatably. And then you can see that, again, in gaze up and gaze down, the patient doesn't have nystagmus of any significant nystagmus. Now, as a part of the spontaneous nystagmus, you usually do the gaze at center gaze, and then you see the effect of fixation. Here you see the area that's in yellow. It's where the patient is given a target. Before that, the patient is complete darkness. But again, this one, we'll talk about this in far more detail in the next webinar. So as I mentioned, what we're looking for in these tests is evidence of nystagmus. Nystagmus, by definition, is a repetitive, involuntary to and fro movements of the eyes. The nystagmus can originate from multiple sources. Some of them are actually not any type of pathology. We can have physiologic nystagmus. So, for example, vestibular nystagmus that's induced by caloric irrigation or by rotation. These are normal manifestation of nystagmus. Optokinetic nystagmus is another form of physiologic nystagmus. And then finally, endpoint nystagmus is if you look far enough to the right or left, and I'm talking about the angles of over 40 degrees, even normal people have some level of nystagmus. And if you want to explore the origin of it, the eye muscles are like any other muscle. If you stretch them far enough, they will not perform optimally. So if you're at the 40 degrees right or left, your eye muscles are stretched to the limit. So occasionally they don't have enough tonic contraction to keep the eyes there. So you see occasionally nystagmus of very small amplitude, intermittent nystagmus, which you see in normal people, especially in older people, just because the muscle tones are affected by age, the same way that any other muscle is affected. So you see endpoint nystagmus more commonly in the older individuals. The only clinical precaution here is that we should not mistake endpoint nystagmus with gaze nystagmus, which is abnormal. So we have to make sure that we're not taking the eyes so far to the extremes that you're generating endpoint nystagmus. The other thing that you should know is that the endpoint nystagmus is affected by alcohol level and by other substances. So you could start seeing the endpoint nystagmus sooner than 40 or 45 degrees off center. So again, it's just a matter of distinguishing this, which is a normal variation, from pathologies that you'll see in a few minutes. So pathological type of nystagmus, it can originate from peripheral vestibular abnormalities or central, whether it's vestibular or non-vestibular. So you can see them in both types of abnormalities. The types of pathologic nystagmus, the most common one we see in the clinic is obviously spontaneous nystagmus, which by definition is present in the absence of visual and vestibular stimulation. Again, we'll discuss that in the next part of the webinar. Gaze-evoked nystagmus is another pathological manifestation of gaze instability, and it's defined by nystagmus that's present only in specific gaze positions. And finally, the positional nystagmus is a type of nystagmus that's present in specific head positions. Finally, there's congenital nystagmus, which by definition is present at birth or shortly after birth, and because of that, we kind of categorize that differently, but it is a form of a pathologic nystagmus. We'll discuss that today at the end of the presentation. So when you see nystagmus, there are important characteristics that you have to remember. And in order to interpret the nystagmus and determine the clinical significance of that, you should pay attention to these characteristics. The shape of the nystagmus, direction of the movement, whether it's fast phases or slow phases, intensity of the nystagmus, which is defined by the slow phase velocity of the nystagmus. You do not usually need to measure intensity in the test without in the test with fixation, because as we'll discuss in a minute, almost any nystagmus with fixation is abnormal. It doesn't have any strength or intensity criteria, but the nystagmus that's seen without fixation, it will need to be the intensity needs to be determined in order to identify whether it's a significant pathologic nystagmus or not. And finally, the effect of fixation, which is a very important factor in identifying or distinguishing central from peripheral nystagmus. And finally, the latency and duration. This type of nystagmus, this type of parameter, latency and duration, is usually reserved for a transient type of nystagmus, which you might see during Dix-Hallpike in patients with BPPV. But on occasions, you'll see it in the gaze test, and I will discuss that in a minute again. All right, now let's talk about the classification of nystagmus based on its shape. The nystagmus slow phase can be different shapes. The most common one we see in the clinic is where the slow phase of the nystagmus is a line. The most common form is a line, like what you see here. This is a constant velocity, linear slow phase, and it's common in peripheral or central vestibular pathways. The other type of nystagmus, the slow phase, is not a line, but actually the velocity is increasing. So as you can see, it starts slowly and spikes toward the end of the slow phase. These are increasing velocity nystagmus. It's common in congenital type of nystagmus. The other type of slow phase is a decreasing velocity. So as you can see, it starts very fast and plateaus toward the end of the slow phase. This is a decreasing velocity slow phase nystagmus. This is common in cerebellar lesions. All three of these types of nystagmus, they're categorized as jerk nystagmus because there's a distinct fast phase and slow phase. So you can see this slow phase here is the arm of this nystagmus that's taking a long time, and then there's a reset in the opposite direction which is the fast phase of the nystagmus. So any nystagmus of jerk-type nystagmus always has a slow phase and a fast phase. There are types of nystagmus where that is not true. For example, pendular nystagmus, which you can see a video of this. I'm going to click on this. So as you can see in the eye movements, there is no slow or fast phase. The eyes are moving with the equal speed right and left. This is called a pendular nystagmus, and again, it's usually seen in patients with congenital nystagmus. Finally, another type where there's no distinct slow phase is square wave jerk nystagmus, which you can see here. This type of nystagmus doesn't have a slow phase. It only consists of fast phases. This is actually not by real definition. This is not a nystagmus. Even though we call it the square wave jerk nystagmus, it's really not nystagmus. It is due to the saccadic intrusion. So normally your saccads are under voluntary control, but in some abnormalities you lose that voluntary control. So the eyes are getting thrown off the target, and then you try to come back to the target. And it's always the width of these square wave jerk nystagmus, it's about 200 milliseconds. That's the intersaccadic latency. So the types where the eyes are staying constant, that usually right around 250 milliseconds or so. And that's how you can separate somebody who has a square wave jerk nystagmus from somebody who has voluntary eye movements. Voluntary eye movements usually have much larger width than 200 milliseconds. We'll discuss this again a little bit more, but these are the different types of nystagmus as far as their shape is concerned. The next characteristic of the nystagmus that you should determine is the direction. Remember that it's not correct to say the nystagmus is right or left. You always have to specify whether you're talking about fast phase or slow phase. Traditionally, we characterize the nystagmus by its fast phases. This is because in the old days, when you looked at the patient's eyes, what you saw was what caught your eyes was the fast phase of the nystagmus. In reality, most of the abnormalities affect the slow phase of the nystagmus. So, for example, if you have vestibular lesion on one side, that asymmetry makes the eyes move slowly in one direction. The fast phase is just serving to bring your eyes back to the center. But because historically we have classified the nystagmus based on the fast phase, we continue to do that. The word or the terminology that we use to identify the fact that we're talking about this fast phase is the term beat. So when you say right beat, left beat, up beat, down beat, you are clarifying that you're talking about the fast phase of the nystagmus. If you want to, for some reason, give the slow phase, you have to specifically say slow phase of the nystagmus is to the right or left. So giving a single direction usually is not enough. You have to specify which direction or which phase of the nystagmus you're talking about. So as far as the direction, the nystagmus can be horizontal, which is a right-left oscillations. This is the most common type of nystagmus we see in the clinic. It could be vertical, which is up and down oscillation of the eye movement. And then it could be torsional. Now, first of all, I want to just clarify, there are times that people think that the combination of horizontal and vertical nystagmus equates to torsional nystagmus. That's not the case. Torsional nystagmus can be purely torsional with no horizontal and vertical component. In fact, you can identify a pure torsional nystagmus if you stand in front of the mirror and tilt your head right or left. You can see that your eyes make a perfectly torsional movement without much of a horizontal or vertical component. So torsional nystagmus is usually classified based on the movement of the upper pole of the eye. So if the fast phase of the torsional nystagmus moves to the right ear, toward the right ear, that's called a counterclockwise rotation. And then if the eye moves the opposite direction toward the right ear, that's a clockwise rotation. I prefer to use the terms torsion toward the left or torsion toward the right. The reason for that is that whenever we talk about the direction of nystagmus, we talk about the direction with respect to the patient. So it's the patient's right or patient's left. And that's consistent throughout the vestibular evaluation. When you talk about clockwise or counterclockwise, that changes. Clockwise, counterclockwise is based on the examiner's point of view. So it's you looking at the patient's eyes to see which direction it's moving. To eliminate that inconsistency, if you say torsion toward the left or torsion toward the right, again, you're talking about the patient point of view. Now, when we analyze the nystagmus, we have to interpret each component of the nystagmus on its own and then combined to look at what effect or what source it could come from. But so generally break down the nystagmus to its three primary components if you see a combination of these, and then interpret each one separately. In the old days, we were taught that if you have vertical nystagmus or torsional nystagmus, it's always central. We know from our experience with BPPV patients that that's probably the terminology is not quite right. What we should say is that if you have purely vertical or purely torsional nystagmus, then that's central. But combination of torsion, horizontal or vertical, it can come from abnormalities in the focal lesions of the anterior or posterior canal. So any combination should be interpreted more cautiously, so not just take that if you have vertical, any type of vertical, it's always central. If there's a combination of torsion, it probably means there's either one of the vertical canals or one of its pathways are affected. So the next classification, as I mentioned, is the intensity of the nystagmus. Intensity of the nystagmus is basically measuring the slow phase velocity of the nystagmus. You do not need to do this if you're just looking at nystagmus with fixation. Anytime you're looking at nystagmus without fixation, this becomes an important factor. Let me just briefly deviate from the PowerPoint content, and I just give you the reason for this. There are other classifications for intensity of nystagmus. For example, people use frequency or actually the amplitude of the eye movement. The reason that the slow phase velocity is the most important feature of nystagmus as far as the intensity is concerned is because it directly relates to how fast the patient thinks their head is moving. So for example, in a caloric test, if the peak nystagmus is about 30-40 degrees, during that phase of the caloric test, the patient feels like their head is moving 30 or 40 degrees per second. That directly relates to the patient's symptoms, that directly relates to how much activation of the vestibular pathways the patient is experiencing. The other parameters that are used sometimes, like frequency, amplitude, they do not have this feature. So back to what we're discussing here. In the old days, when you did not have recordings and you just relied on the examination of the eye movements, the intensity was classified based on how many different positions or how many different gaze positions you could see the nystagmus. So first degree nystagmus was present when the gaze was directed toward the fast phase. So for example, if the patient had left beating nystagmus in left gaze and no nystagmus in any other gaze position, that was called the first degree nystagmus. Second degree nystagmus is the one that's present in the direction of the fast phases, but also in the center gaze. So somebody who has left beating nystagmus in left gaze and left beating in the center gaze, that's a second degree nystagmus. And finally, the third degree nystagmus is that nystagmus that's present in all three gaze positions, right, left, and center. Based on this old classification, The rough interpretation was that if it's a first-degree nystagmus, it's a peripheral disease. If it's a second-degree nystagmus, we don't know. If it's third degree, it's usually central. There's a lot of truth to that, but it's insufficient for accurate interpretation. So now that we have recording, we can do a lot better. In fact, once we test the effect of fixation, that interpretation becomes much more clear. So I don't usually rely on this first, second, third degree nystagmus for interpretation. So the first abnormality we'll discuss is what's called a symmetric gaze-evoked nystagmus. So I'm going to show the videos here. So here's the nystagmus in and you see that the patient has right beating gaze nystagmus. Now let's click on the. Now you can see that the patient has left beating gaze nystagmus. When we look at the tracings, the intensity of both nystagmus is about the same. That's why it's called a symmetrical gaze-evoked nystagmus. A counterexample to that is this patient has right beating nystagmus in the right gaze, left beating nystagmus in the left gaze, but they're not quite the same intensity. It seems to be much more intense in the right gaze compared to the left gaze. This is an interesting nystagmus. It's called bronze nystagmus. This nystagmus is generated by a large acoustic neuroma. And just think for a second and decide with yourself which side is the acoustic neuroma. Since you have 50-50 chance of getting it correctly, I'll just go ahead and explain which one it is. This is a right-sided gaze-evoked nystagmus. It's a right-sided acoustic neuroma. It's a very large tumor. This is an old slide. We don't get these types of nystagmus very often nowadays because before we get to this stage, the acoustic neuroma has to be removed. An interesting feature of this nystagmus is that when you look at the left gaze, this nystagmus has a linear slow phase. So this is actually the vestibular component of the acoustic neuroma. It's because of the compression of the vestibular nerve by the vestibular schwannoma tumors that's generating this left beat nystagmus. If we had caught this patient early on, let's say before the tumor became this large, this will be the only thing you will see. The other side, the right side, this is the effect of the tumor compressing on the brainstem. And if you recall from the shape of the nystagmus, I said if you have a slow phase that's decreasing in velocity, it's usually a cerebellar sign. That's what you see here. The slow phase of this nystagmus is decreasing velocity, whereas this one is a linear velocity. So this is a vestibular pathway nystagmus. This is a central pathway nystagmus, which is what the definition of bronze nystagmus is. All right, so on occasions you get nystagmus that is just present in only a single gaze position, as you can see here. It's a unilateral one. So here you see nystagmus, which is left beating in the left gaze, and it's not present any other place. Now the question we need to answer here is this a central nystagmus, or is it or not? You cannot answer that question without first looking at what effect fixation has on this patient. So if you look at the nystagmus in the absence of fixation, you'll see that the nystagmus is very intense. So this is what's called Alexander's law. In patients who have vestibular nystagmus, we're not talking about necessarily peripheral nystagmus. It could be in the central pathways, but it's in the vestibular pathways, whether it's the canal, the vestibular nerve, or the vestibular nuclei. If you have a asymmetry, this is the type of nystagmus you will generate. And when you look in the direction of the fast phases, the intensity of the nystagmus is the greatest. So that's when the patient is looking to the left beating nystagmus has the greatest intensity. So when we look at the difference between what happens without fixation and what happens with fixation, you can determine that this is a form of a spontaneous nystagmus and not necessarily a central abnormality. So if you were to interpret this finding on its own, it just says that it's a non-localizing spontaneous type nystagmus. Now, if you have a caloric test or a V-hit or something that says this person has a right-sided peripheral lesion, then this is a completely clear, explainable result that the patient has an acute vestibular abnormality on the right, and this is the manifestation of the nystagmus in the Gaze test. So one of the forms of what you might see in the Gaze test is called a rebound nystagmus. It's in fact very close to Gaze-evoked nystagmus. The only difference is that it's characterized by transient type of Gaze-evoked nystagmus. So let's give an example. So if you ask the patient to look at the center gaze and you just wait long enough, and if you look at the patient's eyes, you may not see anything. If you look at the patient, if you ask the patient to look to the left for about 20 seconds or so, you'll see the nystagmus that beats toward the direction of the movement, but then it goes away. So if you ask the patient to look back to the center, you see now nystagmus that beats again in the direction of the movement. So this time you'll see right beating nystagmus, then it goes away after about 20 seconds or so. So anytime the patient changes gaze position, you see a transient type nystagmus that beats in that same direction of movement for about 20-30 seconds. Patients who have gaze-evoked nystagmus may have this in conjunction with their gaze nystagmus, and the significance of it is the same as the gaze nystagmus. So to interpret and to localize the gaze-evoked nystagmus, including the rebound nystagmus, all of these variations are a form of central lesion, localizes to the cerebellum and brainstem, and it's quite common in the lesions of the cerebellar folliculus. So the only thing you have to be careful is that you do not misinterpret spontaneous nystagmus that's following Alexander's law, because you do see that in an absence of with fixation in a single gaze position. And you should not misinterpret endpoint nystagmus as we discussed earlier. The etiologies that can cause this, these are quite varied etiologies. Symmetric type of nystagmus can be caused by drug ingestions like lithium intoxication, metabolic disorders, myasthenia gravis, multiple sclerosis, and cerebellar atrophy. If you have asymmetric one, it has a more localizing meaning. It's usually a cerebellar or brainstem abnormality that could be caused by tumors or infarcts. Bronze nystagmus is a specific type of asymmetric type nystagmus, which is often due to a mass or tumor in the posterior fossa on the side of the gaze-evoked nystagmus. Rebound nystagmus is oftentimes, as I said, we'll see with gaze nystagmus, and it indicates cerebellar atrophy or more focal lesions of the cerebellum. Now, as we discussed, we have another type of nystagmus, which in reality is not nystagmus. That is a square wave jerk nystagmus. As you can see here in the video, the patient's eye movements have no slow phase at all. It's just the back and forth eye movements. And if you look at the tracings, the width of these squares are around 200 milliseconds. So that's clearly indicating that this is not a voluntary eye movement. This is a square wave jerk nystagmus. It's considered a form of saccadic intrusion which is an involuntary firing of the saccade pulses. It throws the patient's eyes off the target, and then the patient needs to correct and come back, and that takes about 200 milliseconds or so. If the patient's eye movements, if that inner saccadic latency is much bigger than 200 milliseconds, that usually means that these are involuntary eye movements. There's some controversy about the normal limits. What you just saw is definitely abnormal. But if you see something much less frequent, especially in older people, you should probably not call that abnormal. If you see, for example, 10 square wave jerk nystagmus in a period of 60 seconds in a patient who's 70, 80 years old, that usually is not considered significant. A young person, even 10 beats of square wave jerk nystagmus could be considered abnormal. So the normal limits are not fully established. There's one paper that has a nice description of these involuntary eye movements and their normal limits. We'll put that later, the reference to that in the follow-up to this webinar. But generally, if you see just a few beats over a 1 minute period, you should be cautious about calling that abnormal. If you do have a significant square wave jerk nystagmus, it is definitely a central lesion, and it usually implicates cerebellum or the basal ganglia. Most of the etiologies that cause this, these are neurodegenerative diseases like multiple sclerosis or spinocerebral degeneration. One form of the nystagmus that you may encounter, and it's definitely a central abnormality, is a periodic alternating nystagmus. And many people abbreviate that to PAN, which is fine, but then you have to make sure that you're not misunderstanding that with the positional alcohol nystagmus. With positional alcohol nystagmus, if they are abbreviated to PAN, there's usually a 1 or 2 after that, which distinguishes whether you're talking about phase 1 or phase 2 of the positional alcohol nystagmus. PAN, that's used for periodic alternating nystagmus, does not have a secondary number to it. As you can see here, this patient initially has right beating nystagmus, then at some point in time that nystagmus changes direction and it goes left beating. And so this is a nystagmus that changes direction in a single gaze or head position. Sometimes people use the direction changing gaze, and they really, what they mean is in the left gaze and right gaze. They don't mean in a single gaze position. So you have to be sure what terminologies you're using. So in periodic alternating nystagmus, the nystagmus changes direction in a single gaze or head position. The characteristic of this nystagmus is that it changes direction every 2 to 4 minutes. It's usually horizontal and conjugate. It is almost always, the ones I have seen, are present both in the with fixation and without fixation. So you'll see this in the gaze test, you'll see this in the position testing. This form of nystagmus can be either congenital or acquired. If it's acquired, there's a medication that's given to the patients called baclofen. That baclofen abolishes this type of nystagmus. It's quite a rare condition, so it's not that you will encounter this often in the clinic, but it causes complication in our interpretation of the test. So because the nystagmus changes direction every 2 to 4 minutes, technically if you wanted to identify this on each gaze or each head position, you had to wait for 2 to 4 minutes to see if the gaze changes direction, which is completely impractical. You will have a very long test. So instead of trying to do something like that, you should really look for inconsistencies. For example, if in the position testing, it's very rare that you might see nystagmus beating in one direction in the sitting position and another direction in the supine position. Or at the beginning of the caloric test, it's very rare that you might see nystagmus beating in different directions in different irrigations at the beginning, in the first 5 seconds or so. So if you see any inconsistencies like this, then you may want to keep the patient in one gaze position or one head position for an extended period of time, see if this kind of periodic alternating nystagmus is present. In general, we don't look for this every time in our tests because it will make the test too long. If you do find it, it's a central abnormality, and it could happen in Chiari malformation and other craniocervical junction abnormalities. It could happen in MS patients. It's quite common in patients who are blind. It's also a complication of anticonvulsant medications. So people who are on seizure medications, you could see them. And as I mentioned, in the acquired type of nystagmus, generally a medication baclofen abolishes the nystagmus. Everything that we have talked about so far have been related to horizontal nystagmus. You can also have vertical nystagmus in the presence of fixation. Here you see a downbeat nystagmus. So this is a clear downbeat nystagmus, and you can see in the tracings that it is a downbeat nystagmus. Localization of vertical nystagmus, as long as it's a pure vertical nystagmus, it is definitely a central lesion. From a diagnostic point of view, downbeat nystagmus has a slightly higher clinical significance than upbeat nystagmus for the reasons that I will mention in a minute. So if you see downbeat nystagmus, it's a central lesion in the posterior midline cerebellum or the underlying medulla. Upbeat nystagmus, almost the same localization, medulla or anterior vermis of the cerebellum. Downbeat nystagmus can be caused by several different abnormalities, including Chiari malformations and the cerebellar degeneration. It's quite common in the cancer patients with the cancer has spread to the central nervous system, or in tumors or the strokes affecting the brainstem or cerebellum. Also, neurodegenerative diseases like multiple sclerosis, vascular diseases like vertebral basilar ischemia, and cerebellar tumors. The etiologies for upbeat nystagmus are very similar, but as I said, there's just a little bit of a less clinical significance for upbeat nystagmus because it could be side effect of the nicotine patches that the patients sometimes wear, or alcohol intoxication, or side effect of some medications. For that reason, we generally give a little bit less diagnostic sensitivity or diagnostic importance to downbeat versus upbeat nystagmus. All the other etiologies are very common between the two. Finally, as I said, I will just mention something about the congenital nystagmus. Congenital nystagmus, it's called that because it's usually noticed at birth or shortly after birth. The most common manifestation is a pendular nystagmus or a jerk nystagmus where the slow phase velocity increases. So oftentimes you see this in the form of spikes in your tracings. Generally, it's conjugate, most often horizontal or horizontal torsional, as opposed to most types of nystagmus that can be suppressed by fixation. Actually, fixation enhances congenital nystagmus, and it's attenuated by convergence. All of those characteristics are hard to separate to distinguish that from other types of nystagmus. The most common identifying factor for congenital nystagmus is that it has a null point. So, for example, if you look at the patient's eye movements from the left gaze or right gaze and move all the way to the opposite side, there's a point where the nystagmus stops and you won't see the nystagmus, and that point is oftentimes not the center gaze. It's usually off-center gaze. So if you're in a train or in a bus and you see somebody reading the newspaper or reading a book and they tilt their head to one side or the other while they're reading this, it's a good indication that that patient might have a congenital nystagmus. So what they try to do is, in order to focus on the items, they tilt their head until what they're looking at is placed in their null point. That's where they can focus and read things. These days, children who have congenital nystagmus, sometimes they go through a surgery to move the null point to the center gaze. This will make functional difference in their life, so they don't have to tilt their head one way or the other. It doesn't get rid of the nystagmus, but it does make the null point the center point. These cases, the nystagmus kind of loses its characteristics that I just described. So it's important when you're doing an interview with the patient to figure out or to ask them if they've had surgery in their childhood for eye surgery, because they may have this. The example here is somebody who has had surgery, so the nystagmus still there, but it doesn't quite match what I just described. The null point is closer to the center point. So, to just summarize what we talked about, in normal variation of gaze stabilization tests, you typically do not see any nystagmus with fixation in any gaze or head positions. If you have strong spontaneous nystagmus or significant nystagmus without fixation, sometimes that leaks through and you see some version of partially suppressed version of that, especially in the gaze toward the fast phases. So that's in spontaneous nystagmus with the Alexander's law component to that. With that exception, everything else should be considered a central abnormality. And again, if you do not do the test the way it should be done, and you have the patient gazing too far, like 40-45 degrees, then you might have endpoint nystagmus. So whenever you have gaze abnormalities with fixation, that's an indication of central abnormality. We will talk in the second part of this webinar in a few months on abnormalities that are present without fixation. So with that, thank you very much for your attention. I'll turn the mic to Lee to continue with this.
Thank you very much, Dr. Barin. A very interesting webinar. It's always interesting to hear about all the different types of nystagmus that we can record and how we can actually visualize those on VNG systems. I'd like to take this opportunity to really just open the floor to any questions that you may have as a result of listening to that webinar. And you can type those into the instant messaging window on the side should you have any. So I'll just give you a couple of extra minutes to do that before we close the webinar session for today. We have a question which has popped up, and the question reads, thank you for a great lecture, Dr. Barin. You spoke about the importance of mental alerting in gaze testing. Do you have any comments on arousal effects, such as anxious patients, high levels of caffeine prior to testing?
Thank you. Great question. Usually patients who are highly anxious and they have excessive amount of arousal, and especially, so for example, you're doing a position testing and they have heard that how bad the caloric testing is going to be, and they're all very anxious, you generally see an increased intensity of nystagmus. It's not always, and you see that also during the first caloric irrigation. So if the patient has been really anxious about the caloric testing, your first irrigation generally is stronger than the remaining three. Once the patient realizes, okay, this was not as bad as they thought it was going to be, in the following irrigations they don't generate as much nystagmus. So yes, if anxious patients and excessive amount of arousal could cause the nystagmus to have a little bit more intensity. It usually doesn't take you into an abnormal range. So for example, if you have a spontaneous nystagmus of 1 or 2 degrees, it's not going to take you to, let's say, 20 degrees per second of spontaneous nystagmus, but it will have some effect. I cannot give you a number, but I think it does have some effect. As far as the caffeine effect, this is one of the things that usually some laboratories tell the patients not to have any caffeine for 24 hours or 48 hours before the testing. But there have been at least 3 very good studies that show caffeine does not have much of an effect on the testing. And in fact, a couple of those studies show that caffeine allows the patients to be a little bit more alert, and they may actually get a better test results than if somebody who's sleepy or the opposite of a person who has mental alertness. So I never, at least the last 15-20 years, I never instructed the patients to be off the caffeine. The arousal or the mental alertness as a result of caffeine is minimal. If anything, it helps with the testing.
Perfect. Okay, so we have another question that's also came through, and that reads, what criteria do you use to consider square wave jerk nystagmus during the spontaneous test as significant?
I use usually 10 beats and 20 beats per second for the difference somewhere between that. So if it's a young person and if they have more than 10 beats of square waves in a 1 minute period, I will consider that abnormal. In an older individual, I will be a little bit more lenient. I will try to have something with somewhere between 10 or 20. If it's a real old person, I will allow them, or before calling it abnormal, I will have at least 15 to 20 beats of nystagmus. Generally, I've never found it to be that close. The call is very obvious in most cases. So it's not going to be, okay, is it 10 beats or 12 beats? Which one of them should I call normal or abnormal? It's either you're going to get 40 of them in 1 minute, or you're going to get 8 or 9. So the distinction is usually easy to make.
Thank you very much again. Okay, so I believe we have a few thank yous which have come through, but no remaining questions. I'll just let Frank finish writing. Fantastic. Okay, so that reads to me as that we have come to the end of the session. So I'd like to thank you all very much for taking the times out of your busy schedules to watch this. And again, you'll find this webinar up on the Academy website, introacoustics.com/academy. So until the next webinar, as we mentioned, this is part 1 of part 2. We have the next webinars published until June of this year, but Dr. Barron's second webinar will come in the second half of the year. So stay tuned to the Academy website, and when we'll send out communication of when exactly that date is. But in the meantime, thank you very much and enjoy the rest of your days.